Good evening, everyone, and thank you for joining us on this not so sunny evening when we're going to talk a bit about prostate enlargement and various treatments for that. My name is Steve Garnett. I'm a consultant urologist. I've been at Benenden for 15 years or so now, and also work in East Sussex in Eastbourne and Hastings, and I have an interest in prostate diseases, prostate enlargement and prostate cancer, although we're going to focus on benign prostate enlargement this evening. This webinar will be recorded, and please do contribute any questions you have through the chat function, question function, and we'll get to those and answer some of those at the end. Okay, so next slide, please. So what we want to talk about this evening is a bit about what the prostate is and how prostate enlargement affects men, but also then moving on to treatment options, including aquablation, which is a relatively new treatment, TURP or transurethral resection of the prostate, which is the most widely performed surgical treatment for prostate enlargement, and also a bit about urolift treatment, which is a smaller treatment that we offer at Benenden Hospital. And then we'll come on to some questions at the end. Next slide, please. So what is benign prostate enlargement? Also used to be called BPH, benign prostate hyperplasia. This is a condition that causes enlargement of the prostate and affects how you pass water, pass your urine. It's very common, affects about 50% of men from the age of 50 onwards, and by the age of 80, about 90% of men will be affected. So about 3 million men in the UK do have symptoms associated with benign prostate enlargement. Next slide, please. So I think this is a really useful slide to look at to try and understand why men get the symptoms that they do when the prostate enlarges. So on the left side, you can see what the normal prostate looks like, and that's the lighter colour organ underneath the bladder. So the bladder obviously holds the urine, and then when you pass urine out, it runs through the prostate. And then when the prostate is enlarged, as you can see on the right side, that prostate enlargement pinches and blocks the way out, the channel out of the bladder. So that is why men get a slow flow, might get difficulty starting passing urine, and the bladder has to squeeze much harder to get the urine out, and that in turn causes bladder problems like going very often, not emptying the bladder, having to rush to the toilet, that type of thing. So really this picture is very useful at understanding in purely sort of physical terms why prostate enlargement causes these symptoms. So next slide, please. So the cause of prostate enlargement is unknown, but it is definitely linked to hormone changes. So we know that testosterone stimulates growth of the prostate, but why that affects some men more than others, we don't really know. And it may be related to changing hormone levels as we get older. Next slide, please. So really, symptoms caused by benign prostate enlargement related really to that slide we've just seen. So obviously the prostate is normally a fairly small size, usually referred to as sort of walnut size, and it's just underneath the bladder, between the penis and the bladder, and as it enlarges, it blocks the way out and causes difficulty starting, passing urine, which we call hesitancy, frequency, and difficulty emptying the bladder. Next slide, please. So how is it diagnosed? First of all, usually most men will see their GP. Sometimes I appreciate that can be difficult these days, and so people do come to us directly. But in an outpatient setting, we would see men and we'd want to do tests to check on the urinary flow rate. So that means passing urine into a machine that measures how well you're passing your water, and we can scan your bladder and see how well you're emptying it. Assessing things like your prostate size, which may be done by ultrasound, and also asking you to fill out some questionnaires about your symptoms and possibly even a what's called a bladder diary to indicate how much you're drinking and how often you're passing urine. So these are all fairly simple outpatient procedures. Next slide, please. In terms of treatment, it may not be that any particular treatment's required in the early stages with mild symptoms, possibly reducing tea and coffee or avoiding drinking later in the evening. That sort of thing might be all that's necessary. Obviously, many men are concerned about prostate cancer, and that would be part of any assessment. For many men, being reassured that they don't have anything to suggest prostate cancer may be enough for them to be happy to live with mild symptoms. For more severe symptoms, there are various different medications. For example, tamsulosin is a very widely prescribed drug which can help relax the prostate and allow men to void a bit more freely. And again, that would usually be the first line of treatment and may be enough for many men. However, all medications can have side effects, so many men don't like being on them long term, or if they're not doing enough and symptoms are more severe, then further treatments involving some form of surgical procedure are likely to be required, and we'll discuss those a little bit further. Next slide, please. So the first treatment we're going to mention is aquablation. This is a fairly new treatment that has been around in the UK for a few years now, but isn't that widely available at the moment. It involves using a minimally invasive robotic assisted procedure in which high pressure water jets are used to ablate or remove the excess prostate tissue. And by doing this, it relieves the pressure on the urethra and allows the urine to flow better. This is performed under general anaesthetic. There's no cuts or incisions. There's an instrument put down the urethra or the water pipe through which the high pressure water jets are fired. We'll show you on the next couple of slides a bit more detail about how that actually works. So next slide, please. So the aquablation procedure is a new approach in that it allows us to more precisely target and remove excess prostate tissue because we use what's called real-time ultrasound. So there's an ultrasound probe placed into the back passage during the time of the operation, and that allows us to image the prostate very accurately and plan where exactly we want to remove tissue from the prostate. And integrated with this is a camera and probe into the urethra, and that is essentially held by a robotic arm which is controlled by a computer, and you'll see on the next slide how we do this, but we map out the area we want to remove by the ablation process, and then the robotic arm guided by the computer does that process for us. So it is a general anaesthetic. It takes about an hour and is usually a 1, sometimes a 2-night stay in hospital depending on prostate size, and there would be a catheter in the bladder again for 1 or 2 nights after the procedure. Next slide, please. So I think we'll run this video in a moment, which makes it a lot easier to understand what I'm talking about. So this is a sort of schematic video showing in outline what happens during aquablation. So what you're looking at now is a side view through the prostate. You can see that metal arm, which is the robotic controlled arm through which the water jets come out right at the end. And that will rotate side to side, and the depth is controlled by the computer after the surgeon has mapped out the area to be removed. And on the picture you can see there, the green dots are the mapping that has been done, showing the area we want to remove of the prostate. The black probe underneath the prostate is the ultrasound, which gives the picture, which is the small picture in the window there, which allows us to see in real time exactly what's happening. So the prostate's a slightly paler pink tissue in this picture. So what we're going to do now is run the video so you can see, rather than me sort of talking, exactly what's happening. So the high pressure water jets run from side to side, a bit like windscreen wipers, if you like, and the depth is controlled by the computer to try and to map out according to that green zone where tissue is removed. The little picture-in-picture there was what we would see through the telescope of the water jets going from side to side. Because we're using the ultrasound to map out exactly where we want to remove, when we get to this part of the prostate now, the furthest out, what we call the apex of the prostate, we're able to just carefully remove tissue at the sides rather than in the middle, because it's that middle area that helps control sexual function and ejaculation, and we don't want to damage that. So I think that's a really useful video, and you can see now just that in that little picture in there, the jet was just coring out the tissue just at the side there on the right as we looked at it. So next slide, please. So the benefits of aquablation is that it does have fewer side effects than traditional treatments. That doesn't usually have any impact on sexual function and much lower risk of affecting ejaculation compared to any other bigger prostate procedures. Has a reduced recovery time and reduced post-operative discomfort. So obviously there's no cuts or incisions, there's no heat used, so there's much less risk of side effects. And because we're using a robotic procedure with real-time ultrasound imaging, that it's a bit more precise. Next slide, please. So that's the aquablation, which is the newest treatment, and I think is a good option for many men. For men who are less concerned about sexual function, the TURP remains a very good option. This is an operation that's been around for a long time now, 40 years or so, and it involves, again, putting an instrument down the urethra or water pipe and coring out the prostate using electrical energy, and that's directly under the surgeon's control, and there's no ultrasound used for this. The instrument is called a resectoscope, and as I say, it uses electrical energy to core out in little bites or little chips the prostate tissue. It's very effective. It works very well for improving urinary symptoms. It's just that it has a higher risk of affecting sexual function. Now, for many men, that obviously is a concern, but there are a number of men for whom that isn't such an issue, and in that case, this would be a perfectly good operation for you with a good durable outcome. Again, it's usually done under a spinal or general anaesthetic with a catheter in for 1 or 2 nights afterwards. And with both of these procedures, you may see a bit of pink blood in the urine for a few days afterwards. Next slide, please. So a TURP, as we said, is a good operation for urinary symptoms, and for these symptoms in particular, having frequency or urgency to pass urine, difficulty starting a weak stream, getting up at night, that's called nocturia or incomplete emptying. So these are symptoms that would be helped by a TURP or aquablation. Next slide, please. So again, for most men we see don't leave things too long and come when they've got bothersome symptoms. But if benign prostate enlargement isn't treated, some of the things that could happen could be recurrent urine infections, bladder stones. Bladder stones usually form when the bladder is not emptying properly. Blood in the urine can be an issue if the prostate's very large. The worst thing that, the thing that we really want to avoid is getting to the point where men can't pass urine and need a catheter placed, and that's an emergency procedure. And really, we do see a number of men in that situation, but it's better to get treated before it's got that far, because if it does get that far, then sometimes the bladder can be damaged and not squeezed so well even after an operation. And relatively uncommon these days is when kidneys are damaged due to really poor bladder emptying and high pressure, back pressure onto the kidneys. So we don't see that so often these days. Next slide, please. So as I said, during a TURP, these little the instruments passed and little chips of the prostate are removed bit by bit to open up the way out and allow a good flow of urine afterwards. Next slide, please. So I think after a TURP, people will have a catheter in place. The urine may be blood-stained for a day or two afterwards, and most people are in hospital for 1 or 2 nights. Next slide, please. Once the catheter is removed, and this applies to all prostate operations, there might be a bit of stinging or burning when the catheter first comes out. You might have to rush to the loo a little bit the first day or so, but these symptoms are pretty short-lived and usually resolve over the first few days after an operation. Next slide, please. So the final treatment I want to talk about this evening is the UroLift procedure. And this is a much smaller procedure that I think fits in the gap between those who may not need such a sort of major procedure but are a bit fed up with medication, or have got side effects from medication, or the medication isn't quite enough. In this procedure, small permanent implants are placed into the prostate, pulling the prostate open, and this improves the flow and bladder emptying and reduces urinary symptoms. This actually isn't done as a local anaesthetic procedure typically. Occasionally we do that, but it's much more comfortable, I've found, for most men to have a short general anaesthetic. Procedure only takes about 15 minutes and is done as a day case. Next slide, please. So in a minute, this will run another video showing you in outline what happens, and what we're looking at here are the 2 lobes of the prostate. And if we run the video now, I'll show you what is done during the UroLift procedure. So in a minute, we'll see a camera instrument coming in, and that's the instrument that fires the UroLift clips out. So that's on the inside of the prostate, which has become blocked. Prostate is pushed away to open it up, and then the UroLift clips are deployed. And as lots of people say to me, yes, they do look like treasury tags, and essentially they're pulling the prostate open to allow better flow and better bladder emptying. So the number of clips that we put in depends on the prostate size, but typically it's about 4. These clips are metal, but they're very small. There's suture or stitch material between the metal implants. And this is a good option for men who want a small procedure, who don't want anything too major doing, who want a day case, and this typically doesn't involve a catheter being placed. I think the downsides of a smaller procedure like this are that you're more likely to need further treatment in the future, and it's not necessarily going to be a definitive treatment for the rest of your life, but it does have low risk of side effects and gives a good moderate improvement in symptoms, better than medication, and allows people to come off medication. So for many men, it's an alternative to taking medicines. Next slide, please. So I think that's a little quick overview of various treatments that we offer at Bennington for benign prostate enlargement. There are other treatments that are available at other places, such as laser treatment, but for most men there isn't really any benefit between laser and TURP, and I would say that aquablation is the one treatment that offers the lowest side effect profile for a major treatment, and UroLift offers the fewest side effects of any of these treatments. So we're going to move on now to question and answer session, which I think is usually quite helpful for people, because often lots of questions that you've thought of will come up. You can see on the screen there the self-pay prices for patients or people who wish to explore those options for themselves. And there is a reduction available for anyone who wishes to seek consultation and applies within a week of this webinar today. So Ollie, are we able to move on to any questions now?
Yes, yeah, thank you, Mr. Garnett, for all of that presentation. We've got quite a few questions that have come through.
Yeah.
Just wanted to say, obviously, we're so pleased to have so many here tonight. I just wanted to say if you could try and keep sort of questions quite brief, and then we'll be able to get through a lot more of them and give you an answer tonight. And if you've left your name, we will be able to get back to you by email if we don't get to your question. So first question is from Marcus. Marcus says he's 66 years old. He's been on finasteride and tamsulosin for 5 years now, and is concerned that he's been on that a long time. And is it a bad thing that he's been on it long term?
So those are two commonly used medicines for prostate enlargement. Tamsulosin, I already mentioned, that's a class of drug called an alpha blocker. It works to relax the muscle in the prostate and open up the prostate a bit, and can have side effects such as causing slightly low blood pressure and dizziness. And some men get generalized or slight fatigue when they take it. And occasionally people can get blocked sinuses. In terms of taking it long term, there don't seem to be any particular problems with taking it long term, apart from those potential side effects. So if you're not getting the side effects and you're fine taking it, then there doesn't seem to be any problem continuing on long term. Finasteride is a different type of drug that works to shrink the prostate down in size. So it works through a kind of hormonal basis. It stops the effect of testosterone in the prostate, and by doing that, it shrinks the prostate down. In terms of side effects, about 1 in 10 men can get erection problems with that drug. About 1 in 100 can get some slight breast enlargement. And very, very rarely, some men can get some mood changes or even slight depressive sort of feelings. Now, again, if you're not getting any of those problems, it does seem safe to take long term. And in fact, probably the longer you take finasteride, the greater effect it has on shrinking the prostate or stopping it from growing at least. So I don't think that we have anything to say that it's not safe to take those long term, but obviously all of these drugs do have some side effects, and for many men they would prefer not to take drugs or deal with those side effects. And in that situation, it may be, it certainly would be worth considering whether an operation is a better option for you.
Brilliant, thank you. And we've got a couple of questions here around testing for cancer beforehand. So Nick asks, do you require a PSA test and DRE prior to treatment to rule out prostate cancer? And Mel asks, how do we decide the difference between an enlarged prostate or a cancerous prostate?
So the PSA is the most useful test in that regard. You've got to understand that as your prostate enlarges with benign prostate enlargement, your PSA will go up as well, but it doesn't go up as much usually as we would expect with prostate cancer. So DRE refers to digital rectal examination, or crudely a finger in the back passage to feel the prostate. Now, there's been a move away from doing that because obviously a lot of men don't like that, but it may be something that's appropriate to do. Certainly, I wouldn't want to say that it definitely wouldn't be something to consider, but obviously, we take into account everyone's personal feelings and everything, and then we certainly wouldn't force someone to have a test they didn't want, but it can be a useful way of helping to distinguish between the two. If the PSA was abnormal, then at that stage we would definitely want to consider whether an MRI of the prostate was appropriate as well. But there are other factors that go into this, such as your PSA series. So what your PSA series being previous PSAs, which is more useful than just a one-off PSA. Prostate volume, which can also be assessed by ultrasound, and also family history, which affects risk of prostate cancer. So yes, there would be an assessment for anyone with urinary symptoms as to whether there was considered to be a risk of prostate cancer, and that could involve various numbers of tests depending on PSA levels and family history, etc.
Great, thank you. Next question is from Trevor, and he asks, do we do any other imaging techniques before the procedure, such as an MRI?
I wouldn't routinely do an MRI unless there was concerns about prostate cancer, but we may do a cystoscopy, which is a look inside the bladder, because actually that might give more useful information than necessarily an MRI scan. But again, that isn't routine. So we wouldn't necessarily need to do any further imaging, although again, depending on individual circumstances, we may do.
Great, thank you. And Peter asks, he says he's over 80 and he's previously been told that not to worry about PSA increase.
Yeah, I mean, PSA goes up with age, so PSA gets higher as we get older. PSA in your 80s is actually quite difficult to even to know exactly what a normal value is, because a lot of men, we haven't got that many sort of records in the past on men over the age of 80. However, so I think it depends a bit on what level you're talking about. But if your PSA has been recorded in the past, it's helpful to compare that to what it is now. It's difficult for me to answer that question on an individual basis without knowing what the PSA level is. But certainly PSA going up to 10 would be quite normal for a man in his 80s.
Great, thank you. And Toby asks, he thought the prostate went around the urethra. Are you suggesting that the urine flows through it?
Sorry, could you just ask the question again? I got interrupted there.
Yeah, no problem. Toby asks, does the urine flow through the prostate or the urethra?
Yeah, so this is a common question. It's because the pictures don't really make it clear, but essentially the prostate and the urethra are one thing. It's not a tube going through an organ. The walls of the prostate are the urethra, so there's no difference. So when we do these operations, the urethra just heals up because it's the lining of the prostate.
I think that sort of relates to this next question from Bob, who asks, how does the treatment work on the gland as it's outside of the urethra, yet the equipment is inside the urethra?
No, so as I said, it's not separate. It's the same thing. So it's not like there's a hose pipe going through a donut or something. It's one and the same. So that's why it works.
Great. This next person asks, can you have an aquablation or urolift if you've already had a TURP?
You can do. Yeah, definitely can do. Either maybe options. Yeah, there's no reason that you couldn't. Yeah.
Great. Next question is from Nick, and Nick asks, how simple is it to reverse the urolift procedure?
You can have further treatments such as TURP or aquablation after urolift. That's absolutely fine. And during those procedures, the urolift implants on the inside of the prostate, on the urethral sort of aspect, would be removed. It's more difficult to just remove the clips without doing that, because they become sort of embedded in the prostate. So usually they would be removed during another procedure like a TURP or aquablation. Those clips on the outside of the prostate are permanent. They're not removed. They can't be removed.
Thank you. Next question is from Charles. Charles asks, he usually gets up twice a night, but the ultrasound shows no enlargement of the prostate. He can empty his bladder fully, which has also been confirmed with the ultrasound. What other things could he look at?
Well, in that situation, First of all, I would say I don't know Charles's age, but getting up once a night is normal over the age of 50. Getting up twice a night is normal over the age of 70. So, although these people are often find it annoying and frustrating, which I do understand, but it is also, normal and part of getting older, I'm afraid. However, in terms of what else can be done, it would depend on whether there are other symptoms such as rushing to the toilet, what we call urgency, maybe going a lot during the day, that type of thing, which might indicate a problem with the bladder, which could be treated with medication. Also, the prostate's not the only cause of blockage to the way out of the bladder. So there are other things. So just having a normal sized prostate doesn't mean that there isn't blockage. So it would definitely need a bit further investigation.
Great, thank you. And Trevor asks, is the catheter removed under sedation?
No, the catheter is just a tube that stays in the bladder, and it only stays in because there's a balloon inflated at the end of the catheter to stop it from falling out. And once that's deflated, the catheter essentially falls out, but it's not something that requires sedation.
Great, thank you. And Andrew asks, he's been diagnosed with an extremely enlarged prostate, prescribed with finasteride, and as well as taking tamsulosin daily, currently self-catheterizing every 2 days. And what would you recommend from the 3 options?
Well, I don't know how large the prostate is, so that does affect things. We don't usually, I think in that situation, I wouldn't recommend Urolift because I think you're going to need a slightly larger procedure. The Urolift is good for slightly less severe symptoms, but in your situation, I think you're going to need either a TURP or aqua ablation, and that would be affected a bit by the size of your prostate. So a normal prostate is around 30 mils in volume, depending on your age. And, an enlarged prostate would be anything above 40, but a very large prostate could be over 150 mils in volume. Now, we don't usually do a TURP over 100 mils in volume, but we could do an aqua ablation on a larger prostate. So it does depend a bit on the prostate size and also other factors such as concern about sexual function and issues like that.
Great, thank you. I think that sort of relates to this next question. Paul asks, what would you recommend for 154 cc?
I think for a prostate that size, I wouldn't recommend a TURP or a Urolift. You could have an aqua ablation. The other option, which I briefly touched on, is there are laser procedures such as HOLEP, which I think have advantages over TURP for a large prostate like that. But my own feeling is that aqua ablation is better than that because a HOLEP laser procedure still causes sexual dysfunction in terms of affecting ejaculation, whereas aqua ablation doesn't. So of the treatments we offer at Benenden, I think aqua ablation for a prostate of that size.
Thank you. And Mike asks, are the changes permanent? He hasn't put which treatments, so I assume you could sort of touch on all of them.
So with any operation or procedure, there's the risk of further treatment being needed in the future, and that that applies to everything from hip replacements to these procedures. So with a TURP, about somewhere around 1 in 10 men have needed further treatment by 10 years after the operation. So that means that the vast majority have not, and we use the same figures for aqua ablation. So most men get at least 10 years out of their operation. Some get many more, but it clearly depends on your age, and there is a chance of needing further treatment.
Thank you. And David asks, does an enlarged prostate cause erectile dysfunction?
No, enlarged prostate doesn't in itself. Some of the treatments, such as the tablets, can affect that. And obviously, erection problems are very common in men as they get older for other reasons and not due to prostate enlargement.
Okay, thank you. Michael asks, does finasteride and tamsulosin become less effective over time?
As I said, the finasteride does seem to keep working, but a lot of men find that tamsulosin becomes less effective over time. And also, even with the finasteride, the prostate can continue to grow. So it is possible that symptoms deteriorate despite the tablets. Yeah.
Great, thank you. John asks, he's been told by specialists that a Urolift is not suitable as he has a 3-lobe prostate. Is a TERP suitable, please?
Yeah.
Age 79.
So what we call trilobe or 3-lobe prostate means there's a middle lobe of the prostate. And in that situation, pulling the sides apart won't help because you've got a big lump of prostate sat in the middle. So yes, a TURP or aquablation would be suitable in that setting.
Great, thank you. Next person asks, if their flow is good, but they wake up 3 times a night, is it worth doing anything?
Well, again, all these things depend how much they're bothering you. So, you know, if this is such a personal thing because some men, you know, get up 2 or 3 times a night and go straight back to sleep and have no problems. Other men get up a couple of times a night, can't get back to sleep and feel exhausted. So it's really hard. But basically, the bottom line is if the symptoms are bothering you and affecting your quality of life, then yes, it's time to get treatment.
Great, thank you. Next person asks, they've had bacterial prostatitis for 30 years now 63, usual symptoms and discomfort sitting. Is aquablation or Urolift suitable for them?
I think I'd need to assess that on a more individual basis because I would have concerns. I doubt. I understand that that's what you've been told, but that I would have some doubts that you've truly got bacterial prostatitis because that would be really surprising to have that for 30 years. I suspect you've got what's called non-bacterial prostatitis, in which these treatments may be an option, but I don't feel I can answer that. That's quite a sort of individual issue, which needs more investigation.
Next question is from Mike, and Mike asks, can they have the Urolift as they have an ICD and they're 83 years old?
An ICD is a cardiac device, a heart device. And the only issue there would be, essentially, yes, you could. The only issue would be around fitness for an anaesthetic, which would need, again, a more personal assessment. But yes, you could have a Urolift.
Great. And Tony asks, since Urolift involves metal implants, does this affect MRIs in the future?
Yeah, there's a slight impact on MRIs, MRIs of the prostate, nowhere else. And the impact is only in terms of getting a bit of distortion of the image. So it's not, it doesn't set off metal detectors or anything like that. And it doesn't prevent you from having an MRI scan, but you get a bit of blurring around each implant for about 2 millimeters. And it's not really an issue as long as you let the team know that, or the MRI people know that you've got the Urolifts. It shouldn't be a problem.
Thank you. Next question is from Charles, and Charles asks, they've been diagnosed with benign prostate enlargement and prescribed finasteride and tamsulosin, and they're interested in the non-invasive treatment, I assume aquablation, and if successful, will they have to continue medication after treatment?
No, the idea of all of these treatments is that once you've had the procedure, you don't need any medication.
Thank you. And excuse my pronunciation of this. The next question asks, they've been taking anfusozin for a while.
Alfuzosin, yeah.
Are these effective as tamsulosin?
Yeah, alfuzosin is another alpha blocker, so the same class of drug as tamsulosin. In fact, many people find alfuzosin actually has slightly fewer side effects than tamsulosin, so it's definitely as effective. Yeah.
Great, thank you. And John asked, do all types of surgery reduce or stop hematuria?
So hematuria is blood in the urine. I mean, clearly it depends on the cause of the hematuria. There are many causes of blood in the urine, and that needs to be investigated and checked out because it could be related to the bladder or kidneys or other things. But if the hematuria is related to the prostate, then I wouldn't say the Urolift would help with that, but the TURP or aquablation often can.
Okay, thank you. Peter asks, in the meantime, to help with night frequency, what time should he stop drinking?
Well, again, it depends when you go to bed. So, you know, people obviously go to bed at different times, but ideally you should stop at least 4 hours before going to bed.
Okay. And Roger asked, how severe should symptoms become before being of concern? The severity of my symptoms can vary. I'm currently on no medication, and his GP suggested no treatment required at the moment.
Yeah, I mean, that's one of those things that it's really hard for me as a doctor to say to you, oh, you need to have treatment. Clearly, at one end of the sort of spectrum, you've got people who end up not being able to pass urine, having a catheter, having their kidneys affected, getting infections, and that's clearly requires treatment. But at the other end, it's really a question of when you feel that the symptoms are bothering you enough to want to go through and have something done, which is why we would usually start on tablets, because it's non-permanent and doesn't have long-lasting side effects. So usually people with mild symptoms would start on tablets to see if they feel their life is better when they're on the tablets. In terms of contemplating surgery, that's a sort of discussion between me as a surgeon and you as the patient as to when things are bothering you enough to feel like you want to go through a procedure.
Makes sense, thank you. And can tamsulosin have an effect on sexual function?
Yeah, unfortunately, all these medications can affect erections. So tamsulosin can, in a small number of men, cause erection problems and also can affect ejaculation as well. So yeah.
Okay. And Martin asks, are there clinical reasons for recommending TURP versus aquablation, or is it patient preference?
I would say it's mainly patient preference, apart from prostate size. So TURP is not recommended for very large prostates, but apart from that, it would be mainly patient preference in terms of priorities and risks that you're happy to accept, side effect risk. So yeah, generally patient choice.
Thank you. And if the patient has aquablation or Urolift, does the prostate re-enlarge over time? And what's the usual timescale if so?
Well, yeah, I mean, I think I touched on that before about how likely it is to need further treatment. So with Urolift, as it's the only one that doesn't actually remove any prostate, you are more likely to need further treatment. And most people get a good benefit for 3 to 5 years, but are likely to need further treatment after 5 years. With TURP and aquablation, most men get 10 years, but may need further treatment after 10 years, although the majority don't.
Okay, thank you. And Nick asks, he's waking up on average 3 times a night and he's 65. How unusual is this? He's not taking any treatment at the moment.
Yeah, I mean, I think it's a little, it's, you know, you probably need to ask your friends. It's a bit unusual 3 times a night, but having said that, I would say once or twice a night's pretty common. So again, with these things, it really depends on how much it's bothering you. Like I said, if you wake up 3 times a night but go straight back to sleep, it's probably not too much of an issue. The other issue that many men have to consider is their partner. So if you're getting up 3 times a night and waking up your partner every time, that might be a time that you're being told to get treatment.
Thank you. Next question asked, they're 65 and they have an enlarged prostate of 75 milliliters. They've been taking tamsulosin. Should they also do something to shrink the prostate? They've been offered TURP, but reluctant to have surgery.
Well, on the face of it, finasteride would be an option. As I said, there are potential side effects from finasteride, particularly with erections and very rarely with breast enlargement, but many men find it very helpful, and it certainly would be the next step, other than surgery. Yeah.
Great, thank you. So this person's had a sonography report done of their right kidney, and it shows a hypercoic area in the upper pole, which may represent parenchymal scarring. Can mild prostate enlargement be a cause of this?
No, is the short answer. I would not expect that.
Sorry, so I'm going through the questions we haven't touched on. Is the low flow of urine likely to progress further?
Most prostate symptoms are progressive, so they slowly get worse over time. So quite possibly, yeah. I mean, there's not a lot of information there, so but possibly, yeah.
Okay. Next person asked, they've been advised by a urology specialist to stop taking finasteride as it didn't seem to have an effect after 8 months. What would be your thoughts on this? They're aged 79.
Yeah, I mean, finasteride does take a good 6 months to really have a significant effect. So, if you've got no benefit after 8 months, it's maybe that it's not going to really make much difference to you. So, I wouldn't criticize that, but equally, there's probably not much harm for carrying on for a year and seeing if, at that stage, if it still made no difference, it's probably not going to.
Okay, great, thank you. And I think you touched on this earlier, but I've had a couple of questions come up again on PSA tests not being available for people aged over 80. Is that true?
That's not something I've come across before. I think that the values are less, so what we call the normal values are less well defined over the age of 80, simply because there haven't been in the past lots and lots of sort of PSA tests done on men over the age of 80. So it's harder to say exactly what's normal, but I'm not aware of any guidance that says you can't have your PSA tested. I would and do quite frequently check PSAs on men over the age of 80. I wouldn't be too concerned at a low level, but the issue would be to determine whether there was a concern about prostate cancer, and if the PSA was very high, that would be a concern. So I don't know why you shouldn't have your PSA tested over the age of 80. It wouldn't be a routine thing, done as what we would call screening, but if there were symptoms or concerns, then it would be a reasonable thing to get done.
Okay, thank you. Next person asked, they've got long-term Addison's disease, which is very stable. Would this be a problem with any of the procedures? They're 77 years old.
No, obviously Addison's disease affects hormone production from the adrenal gland, but it's not an uncommon situation for us to operate on people with Addison's disease and give steroids at the time of surgery and just carefully manage that. So no.
Okay. And the next person asked, they take finasteride and their PSA went down to 1.8. is this safe as it could mask a larger PSA reading?
Yeah, so it's actually the opposite of that. It is safer. It is safer to monitor your PSA once you're on finasteride, because we know that your PSA is halved by finasteride. So once you've been on finasteride for 6 months or so, if your PSA was, I think you said 1.8, we know that your true value is double that, 3.6. So that's fine. We know what the level is, but equally your PSA should be going down. And if your PSA starts going up when you're on finasteride, that's a greater concern. So in some ways, being on finasteride actually makes the PSA a bit more useful.
Great, thank you. Next person asks, does regular spinning or cycling aggravate the prostate?
Yeah, I mean, long cycle rides with a hard saddle can press up in the perineal area and push on the prostate. So if you're not getting any problems or symptoms, then absolutely fine. But some men, particularly with prostate inflammation or prostatitis, can find that cycling makes it worse.
Okay, thank you. This next person asks, they've been prescribed an alpha blocker for BPH, but recently needed a cataract operation. So the surgeon had to take certain measures to stop the iris collapsing from the procedure. That's their question, but I suppose maybe is there an alternative to taking alpha blocker if they were to have a second cataract procedure?
No, I mean, this is a well-known issue, and normally you would stop your alpha blocker 2 days before your cataract surgery, and it's not an issue. So it's something that should be picked up, and you stop taking it for a few days before the operation and start again afterwards.
Okay, thank you. Next person asks, they've got a 75mm prostate. Is this suitable for Urolift?
In terms of size, yes, but I don't know about the shape and other factors, but the size is not doesn't exclude Urolift yet.
Okay. This person's been prescribed alfulozin.
Alfuzosin, yeah.
That's it. And apparently this has fewer side effects than tantalozin.
Mm-hmm.
What would be your recommendation between the two?
I think I've already answered that, to be honest. I've already said exactly that alfuzosin can have fewer side effects, but they're both equally effective.
Okay. With TURP, can it cause blood in urine up to a year afterwards?
Yes, that's possible. You can get weak, sort of fragile blood vessels where the operation's been done, and they can bleed more easily. So it's not common, but occasionally people do get bleeding long term after surgery. So it's possible.
Okay. Just as we're coming to the end, there's quite a few questions around sort of medications and is it okay to be on the various ones long term? Are there any that are not okay to be on long term, or are they all okay?
I mean, I think we've touched on long-term tamsulosin and finasterides, and those are the main prostate drugs. So they do seem to be safe long-term. Yeah.
Okay, thank you. Right, I think that's all we've got time for in terms of questions, but if you've left your name, we will be able to get back to you by email if the answers haven't covered them already. I'm just going to move on. So as a thank you for joining tonight, we're offering 50% off the value of your consultation, and that's for a limited period for 7 days after this presentation. You'll also get a call back from your dedicated private patient advisor. You'll get an email with the recording of this session, treatment information, and also loyalty reward points. We'll also keep you up to date on news, future events, and offers at the hospital if you've opted into our emails. We'd also really appreciate it if you could take a moment to complete the survey that will come up at the end of this session. It really helps us to improve any future webinars that we host. It's just good to get your thoughts and feedback. If you'd like to speak to someone or book your consultation, our private patient team is available until 8 p.m. this evening. Alternatively, they're available 8 a.m. to 6 p.m. Monday to Friday, and you can use the number that's on the screen at the moment for that. We also have more upcoming webinars on a range of topics. The next ones include orthopedics, hand surgery, and varicose vein treatment. You can sign up to any of those via our website. So on behalf of Mr. Garnett and everyone else here at Bedden Hospital, thank you for joining us this evening, and we hope to hear from you soon.
Thank you. Good night.